The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 45, Lesson 5, Long-Term Urinary Catheters, Their Role and Management of Complications. The AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology.
AUA Update Series, Volume 45, Lesson 5, Long-Term Urinary Catheters, Their Role and Management of Complications. Authors, Ida Nabedi, MD, and Evgeny Kridine, MD. Introduction. Chronic urinary retention and incontinence are among the most common conditions managed by urologists. With a multitude of management options, both clinical evidence and long-standing practice suggest that indwelling catheterization is the least preferred. Yet every urologist can attest to having a cadre of patients who are managed in exactly this manner. Comorbidities, patient preference, and provider comfort are some of the factors influencing the choice of indwelling catheterization as a long-term management option for retention and incontinence. Indeed, indwelling catheters are often simple to manage and convenient for both patient and provider. They do not require major surgery. A suprapubic tube can be placed in minutes and is associated with negligible recovery. Indwelling catheters do not necessitate that patients carry supplies for clean intermittent catheterization or, in wheelchair-bound individuals, search for accessible bathrooms to self-catheterize. Indwelling catheters can also provide relief for severely incontinent patients with perineal skin injury secondary to urine-induced dermatitis. For patients with diminished cognitive or upper extremity function, indwelling catheters improve independence. Likewise, caregivers benefit from greater flexibility if they are not required to regularly change incontinence aids, e.g. diapers and pads, or perform clean intermittent catheterization on a strict schedule. Yet indwelling catheters are associated with many complications. UTIs, intermittent obstructions, and upper or lower tract stone disease are just some examples. While suprapubic catheter placement is a quick procedure, it is not without risks. Among these, bowel and vascular injury can be devastating. Loss of bladder capacity and compliance commonly occur with long-term catheterization, and an increased risk of bladder malignancy has been a major concern. In this lesson, we will review indwelling urinary catheter use by describing the following. 1. The typical patient for whom management with an indwelling catheter is appropriate. 2. The advantages and disadvantages of different catheter types. 3. Indwelling catheter complications and their management. Who gets an indwelling catheter? The decision to proceed with indwelling catheter management as a long-term solution to urinary retention or incontinence is typically based on a balance between the perceived benefits and risks, evaluated by both the patient and caregivers in collaboration with the medical team. Given the multitude of scenarios in which indwelling catheter management is considered, it can be helpful to address them according to the underlying condition. Here, we will examine 3 broad pathologic disruptions of lower urinary tract function that make indwelling catheterization an option for long-term management. 1. Non-neurogenic urinary incontinence. 2. Neurogenic lower urinary tract dysfunction. 3. Non-neurogenic urinary retention. Non-neurogenic urinary incontinence. Managing urinary incontinence with an indwelling catheter seems to run counter to the basics of urological training, and indeed should be a last resort measure when all other therapies have failed. However, the point at which all other therapies are considered exhausted is subjective and patient-dependent. An elderly patient with dementia and severe detrusor overactivity is hardly a candidate for ileocystoplasty, bladder augmentation. Likewise, an incontinent patient with loss of bladder awareness due to a stroke will not be cured by any of the lower urinary tract-directed therapies at our disposal. Finally, a patient with diminished mobility will not be able to walk to the toilet, no matter how much intravesical onabotulinum toxin therapy they receive. Using our medical and surgical tools, we can make a patient's lower urinary tract retain urine. However, retention without incontinence is just one function of the lower urinary tract. The ability to empty the bladder and maintain social continence are equally important. Trading one problem for another by making the lower urinary tract continent but rendering it unable to empty typically defeats the original purpose of treatment. When faced with a complex patient in whom additional treatments will not make a difference or may exacerbate the situation, Effort should be made to manage incontinence with incontinence aids or external collection devices. The latter can provide better satisfaction and a lower risk of complications than indwelling catheters, although with downsides. Especially in the elderly, urinary incontinence often coexists with retention, which external collection devices will not address. Devices such as condom catheters may be difficult to maintain in place, and patients may find them uncomfortable. Managing incontinence with diapers or pads requires close care by the patient and their caregivers. Without frequent changes and adequate skin care, severe perineal skin injury can result. Given the complexities of healthcare systems in the U.S. and around the world, relying on external collection devices or incontinence supplies can lead to unacceptable financial toxicity for many patients and families. Neurogenic lower urinary tract dysfunction. Catheterization is central to managing neurogenic lower urinary tract dysfunction, especially in conditions such as spinal cord injury and multiple sclerosis that affect the spinal cord. The neurologic deficit in these conditions often precludes complete bladder emptying, making catheterization crucial for preventing UTIs, maintaining low bladder pressures, and protecting upper tract function. Clean intermittent catheterization is the preferred method in this setting, endorsed over indwelling catheterization by the AUA Neurogenic Lower Urinary Tract Dysfunction Guideline. However, the guideline recognizes that intermittent catheterization may not always be feasible. Female patients and individuals with diminished upper extremity function, e.g. quadriplegics, or unfavorable body habitus, e.g. due to obesity, may find clean intermittent catheterization cumbersome or impossible. Reliance on caregivers for clean intermittent catheterization is another important factor that can diminish quality of life, making indwelling catheterization more desirable. Paradoxically, neurogenic lower urinary tract dysfunction patients with a high level of independence may also request an indwelling catheter if they perceive clean intermittent catheterization to be time-consuming, uncomfortable, or disruptive to their daily schedule, particularly those with some level of preserved sensation who may find the procedure unpleasant. At the other extreme, severely disabled, e.g. bedbound neurogenic lower urinary tract dysfunction patients often decline clean intermittent catheterization because of caregiver unavailability or reluctance to increase caregiver burden. Generally, we encourage patients with good upper extremity function to manage their lower urinary tract with clean intermittent catheterization. If incontinence between catheterizations is a major concern, reassurance should be provided that it can usually be addressed by minimally invasive measures, such as intravesical botulinum toxin injection. If these therapies are unsuccessful, ileocystoplasty, bladder augmentation may be discussed. Given the potential short and long-term risks, however, we do not push this procedure if the patient prefers an indwelling catheter. Patients with some upper extremity function who are limited by body habitus or anatomy are treated similarly. Many of these issues can be addressed by an occupational therapist experienced in managing neurologic conditions. As with ileocystoplasty, the patient must be highly motivated for these interventions to be successful. Non-neurogenic urinary retention. Before therapy for urinary retention is initiated, the condition should be classified as symptomatic or asymptomatic and as high risk or low risk. Low-risk asymptomatic urinary retention warrants only observation without further intervention. Able-bodied patients without neurologic comorbidities can develop symptomatic retention due to bladder outlet obstruction, detrusor underactivity, or a combination of them. Before a symptomatic patient is relegated to long-term catheter use, the lower urinary tract should be evaluated, commonly by urodynamics, to determine the etiology of retention. If bladder outlet obstruction is confirmed, the patient's comorbidity should be weighed against the risks of treatment, and medical or surgical intervention should be offered, given the typically high success rates. By contrast, urinary retention caused by detrusor underactivity is less likely to respond to treatment. Sacral nerve stimulation, the only U.S. Food and Drug Administration approved therapy for non-obstructive urinary retention, has an approximately 40% to 70% success rate, which may be even lower for certain etiologies. Management of patients with complex voiding dysfunction, i.e. those with coexisting bladder outlet obstruction and detrusor underactivity, is beyond the scope of this lesson. But assessing an individual's comorbidities and motivation is especially important. When medical or surgical treatment is ruled out, the choice between intermittent and indwelling catheterization follows a similar paradigm to urinary incontinence and neurogenic lower urinary tract dysfunction. Although clean intermittent catheterization is generally preferred over indwelling catheterization, the evidence supporting this preference is weak. As in other scenarios, the feasibility of clean intermittent catheterization depends on patient capability or caregiver availability. Which catheter? Once the decision to manage the lower urinary tract with a chronic indwelling catheter is made, the patient and the medical team must determine which type of catheter to use. Point of entry. The first branch of this decision tree is whether the catheter will be placed urethral or suprapubically. In general, we recommend a suprapubic catheter because it poses no risk of urethral injury or bladder outlet dilation. While upsizing a urethral catheter is sometimes attempted to improve drainage, this usually exacerbates urethral trauma and bladder neck damage via pressure necrosis over time. It is not uncommon for men with chronic urethral catheters to develop iatrogenic hypospadias and for women to develop a dilated incompetent bladder outlet. While iatrogenic hypospadias is often merely a cosmetic issue, a devastated bladder neck can lead to severe incontinence, ultimately requiring incontinence supplies, surgical closure, or reconstruction. The risk of hypospadias and bladder neck injury increases in patients with diminished sensation, e.g. those with neurogenic lower urinary tract dysfunction or who are severely debilitated, or with inadequate catheter care. In contrast, a suprapubic catheter can be upsized as needed for adequate bladder drainage without worrying about tract injury. Another important advantage of suprapubic catheters is that unlike urethral catheters, they do not interfere with sexual function in patients who are concerned about this aspect of care. The AUA Neurogenic Lower Urinary Tract Dysfunction Guidelines cite several studies comparing urethral catheters and suprapubic catheters. One pooled analysis suggested that suprapubic catheters may be associated with fewer symptomatic UTIs than urethral indwelling catheters. However, urethral catheters appear to carry a lower risk of bladder stone formation and obstruction. The overall evidence supporting these findings remains limited. Consequently, the AUA Neurogenic Lower Urinary Tract Dysfunction Guideline recommends suprapubic catheters for long-term bladder drainage primarily due to their lower risk of bladder outlet injury. Urethral catheters offer advantages in two key scenarios. First, patients who are incontinent due to an incompetent bladder outlet may remain incontinent after suprapubic catheter placement, as urine preferentially escapes via the urethra. Second, while suprapubic catheter placement is a minor procedure, it carries inherent risks. Some complications, hematuria, dislodgement, or pericatheter leakage, are minor and typically present in the immediate postoperative period. However, suprapubic catheter placement can also lead to rare but potentially serious complications, such as bowel and vascular injury. Although uncommon, bowel injury remains one of the most concerning complications. Reported rates vary widely from 0% to 2.7% in different studies. A 2019 meta-analysis suggested using a rate of less than 0.25% when counseling low-risk patients, e.g. no prior abdominal surgery, favorable body habitus. The British Association of Urological Surgeons has identified two major risk factors for bowel injury during suprapubic catheter placement. 1. Previous abdominal surgery, and 2. Inability to distend the bladder adequately. Placement technique is also important. In general, techniques are categorized as open or laparoscopic, image-guided or landmark-based, such as a percutaneous kit, or a urethral sound, such as a Loesley retractor. An open or laparoscopic or image-guided approach should be considered for patients with a history of abdominal surgery, especially those involving mobilization of the peritoneal cavity and the space of retzius, such as laparoscopic prostatectomy, or for those in whom the bladder cannot be easily distended. Image-guided suprapubic catheter placement using ultrasonography requires significant expertise, as identifying interposed bowel loops can be challenging. For this reason, we typically refer patients requiring this approach to interventional radiology. A single-center retrospective review of 549 image-guided suprapubic catheter insertions by an interventional radiology group identified 2 bowel injuries, 0.3%. Notably, one of these injuries, a tube malpositioned in the rectum, occurred during CT-guided placement in a patient with a contracted bladder, underscoring that advanced image guidance does not entirely eliminate the risk of this complication. Catheter material. Indwelling urinary catheters are usually made of latex or silicone, and less commonly PVC. Surprisingly, only a few studies have compared the effects of catheter material on patient outcomes. A 2012 Cochrane review identified only 3 such studies and concluded that there was insufficient evidence to demonstrate superiority of one material over another. However, silicone catheters do have notable advantages. They typically have a larger gauge for the same French size, allowing better drainage, and silicone causes less tissue reaction than latex. Silicone is also less likely to elicit an allergic response. Because of these differences, the British Association of Urological Surgeons preferentially recommends silicone catheters for long-term drainage. Despite these benefits, some patients prefer latex catheters because they tend to be less stiff than silicone. As a result, suprapubic catheter users, in particular, may find latex catheters more comfortable. Multiple catheter coatings have been developed to minimize complications, such as urothelial trauma, hematuria, catheter encrustation or obstruction, and UTIs. Mineral, silver alloys, and antibiotic coatings have been studied but have not demonstrated superiority over uncoated catheters. Newer coatings and materials, such as Zwitter-ion integration into the silicone backbone, continue to be explored. Preliminary studies of Zwitter-ionic-coated catheters have demonstrated high patient satisfaction, and early results from ongoing trials indicate reductions in cellular activity, UTIs, and encrustation. However, these novel techniques have yet to undergo rigorous long-term clinical testing. Complications of indwelling catheters and their management. More than half of chronic indwelling catheter users experience catheter-related complications. These include UTIs, hematuria, catheter encrustation and obstruction, bladder stone formation, and urethral or bladder erosion, among others. In this section, we will present a case-based review of these complications, their management, and some of the controversies. Case 1. A 42-year-old man with a cervical spinal cord injury manages his bladder with a suprapubic tube exchanged monthly in the office. He presents for his routine catheter change and reports that he had blood in the urine about 2 weeks after his last exchange that resolved spontaneously. On exam, his urine is cloudy but yellow. His exam is otherwise unremarkable. A urinalysis, UA, shows greater than 100 white blood cells, greater than 100 red blood cells, nitrites, and many bacteria. For a patient who is not a catheter user, gross hematuria would immediately trigger a hematuria evaluation, consisting of cystoscopy and upper tract imaging. However, initiating a hematuria workup for an indwelling catheter user requires more subtle clinical judgment. Traumatic hematuria in the context of catheter exchange is very common and can occur with every catheter change. As a result, we generally do not work up patients who experience hematuria in the period surrounding the exchange. On the other hand, hematuria outside of this period should raise a red flag, especially if the patient denies other symptoms, such as UTI. This triggers a standard hematuria evaluation. A more difficult clinical decision arises when the patient endorses hematuria while having UTI symptoms, or when microscopic hematuria is discovered on a urinalysis. With respect to the latter, it is rare to see isolated hematuria on urinalysis, but when this does occur, we do initiate a hematuria evaluation. When hematuria occurs in the setting of UTI symptoms, we monitor the patient for resolution of symptoms and hematuria with antibiotics, and if both resolve, we will forego hematuria evaluation. However, for recurrent hematuria in the setting of UTI symptoms, we will perform a cystoscopy to rule out bladder pathology, such as bladder stones. Cystoscopy and bladder cancer in chronic catheter users deserve a separate mention. Indwelling catheter use, especially over the course of many years, appears to be a clear risk factor for developing bladder malignancy. Yet multiple studies have found that the use of screening cystoscopy in this population does not lead to significantly improved cancer detection rates. As a result, the AUA Neurogenic Lower Urinary Tract Dysfunction Guidelines strongly recommend against screening cystoscopy in this population. Because of mucosal irritation caused by a chronic indwelling catheter, differentiating between inflammatory and malignant changes can be extremely challenging in this setting. Therefore, while screening cystoscopy is discouraged, we have a low threshold to biopsy in the setting of hematuria and abnormal bladder mucosal findings. Case 2. A 24-year-old woman with myelomeningocele who manages her neurogenic bladder with a suprapubic tube presents to clinic for her scheduled catheter change. She reports that she is suffering from frequent UTIs, having gone to urgent care every 6 to 8 weeks with a UTI. Every time, she receives a prescription for antibiotics, but bounces back to urgent care a few weeks later. About 6 months ago, she went to the emergency room at a local hospital and was admitted for 7 days to receive IV antibiotics. On exam, she is afebrile, with stable vital signs. Her urine is yellow and cloudy. Urinalysis is positive for nitrites and shows greater than 100 white blood cells, 50 red blood cells, and many bacteria. A urine culture returns 48 hours later with greater than 100,000 Escherichia coli. Colonization with enteric organisms is common and expected with prolonged catheter use. In addition, symptoms such as urgency, dysuria, and frequency may be absent because of diminished or altered sensation in some indwelling catheter users, such as those with neurogenic lower urinary tract dysfunction. Thus, the combination of a positive urinalysis or urine culture and symptoms, which are highly specific for a UTI in the able-bodied population, are usually much less useful in patients who are chronically catheterized. Patients with indwelling catheters may report a variety of symptoms that they may associate with a UTI, such as foul urine odor, cloudy appearance of the urine, increased pericatheter or urethral incontinence in suprapubic catheter users, back pain, suprapubic pain, and in the case of patients with some spinal lesions, increased autonomic dysreflexia. The provider then faces two challenges. One, to determine whether the symptoms are caused by bacteria colonizing the lower urinary tract. And two, in the case of recurrent symptoms, how to prevent them. A careful history and some detective work are often necessary to address the first challenge. First, it is important to educate the patient about symptoms, and that symptoms are often nonspecific to UTI. Colonization is expected to lead to unusual urine odor and opaque appearance, and unless these symptoms are distressing to the patient, they do not require further evaluation and treatment, just as with positive urinalysis or culture in the absence of symptoms. It is important to educate the patients and providers to avoid obtaining urinalysis or cultures when new or concerning symptoms are absent. Patients often present to emergency departments for management of comorbid conditions, where urine samples are obtained reflexively. This can lead to antibiotic overutilization, promoting the selection of resistant bacterial species. It is best practice to obtain urine samples from a freshly placed catheter to minimize the confounding effect of colonized biofilm. On the other hand, symptoms such as pain, incontinence, or increased autonomic dysreflexia, i.e. those that can cause direct harm to the patient, require a closer evaluation. The temporal relationship between these and other urinary symptoms, such as hematuria or change in urine odor or color, and improvement in symptoms with urine culture-directed antibiotics, can support a urinary etiology and diagnosis of a symptomatic UTI. Once the diagnosis of recurrent UTIs is established, their cause and a preventive plan must be established. Cystoscopy and upper tract imaging are standard techniques to rule out the presence of foreign bodies or stones in the urinary tract. Assuming that these are negative, the patient and caregivers must be educated on proper catheter care, such as maintaining the drainage bag below the level of the bladder, minimizing breaking the sterile seal between the catheter and the drainage bag. Saline, tap water, or antibiotic solution irrigation has shown promise in decreasing the rate of recurrent UTIs in chronic catheter users. In these scenarios, we usually begin with non-antibiotic irrigation and progress to polymyxin, neomycin, or gentamicin if the former is ineffective. We rarely use prophylactic oral antibiotics for recurrent UTIs in chronically catheterized individuals, usually relegating this option to the last resort when all other therapies are exhausted. Case 3. An 89-year-old man with post-stroke dementia and urinary retention manages his bladder with a suprapubic tube. Over the last year, he has had 6 visits to the emergency department for catheter obstruction. He presents to the clinic for his scheduled catheter exchange. On exam, he has a latex suprapubic catheter in place. When the catheter is removed, significant calcifications in the catheter islets are noted. Obstruction is a very common complication of indwelling catheters, frequently necessitating unscheduled visits for catheter exchange. Ensuring optimal urinary drainage is critical for preventing this complication. Thus, educating patients and caregivers on proper catheter care is paramount. Catheter encrustation and obstruction are especially common for suprapubic catheters. The position of a suprapubic catheter in the bladder can promote incomplete drainage and stagnation of urine. Catheter material and design can play a role in mitigating this risk. Further innovations in catheter design to promote complete drainage and resist biofilm formation on the catheter surface also hold promise for ensuring patency. Although any urinary pathogen can lead to biofilm formation and catheter obstruction, Proteus mirabilis is especially adept at urinary crystallization. Multiple studies have suggested that eliminating Proteus attenuates the risk of catheter obstruction, and we do treat with Proteus-directed antibiotics when recurrent catheter obstruction is present and this organism is identified in the urine. Urea-splitting organisms like Proteus alkalinize urine, forcing crystals of calcium and magnesium phosphates to precipitate and form obstructing concretions on the catheter. In fact, a specific pH range is required for this phenomenon to occur. For instance, struvite crystallization is accelerated at a pH of 7 to 8.4. Thus, urine can be both acidified, e.g. with citric acid, glucono-delta-lactone, and magnesium carbonate solution, or alkalinized, e.g. with increased oral fluid and citrate intake outside of this range to prevent crystal formation. Finally, mechanical bladder irrigation can also be utilized to prevent catheter obstruction. As for UTI prevention, we generally start with saline or water irrigation and escalate to antibiotic irrigation as needed. While we do not adhere to a specific protocol, frequency and volume of irrigation are generally tailored to the frequency and severity of catheter obstruction. Case 4. A 65-year-old woman with advanced multiple sclerosis who manages her neurogenic bladder with an indwelling Foley catheter presents to the clinic with complaints of continuous incontinence. Her catheter is exchanged at her nursing facility monthly. Because of increasing incontinence, her catheter has been sequentially upsized from 16 French to 22 French. The retention balloon has also been upsized to 40 milliliters. On exam, the urethra is patulous, and there is continuous urine leakage around the catheter. Bladder outlet injury is an unfortunate complication of chronic urethral catheterization. As mentioned previously, upsizing the catheter diameter or retention balloon is almost never the right answer to pericatheter leakage. In the earlier stages of chronic urethral catheter use, i.e. the first months to years, the most common cause of pericatheter leakage is detrusor overactivity rather than an outlet problem that a larger catheter attempts to address. It is not uncommon for urethral leakage to worsen after placement of a suprapubic catheter, and the etiology of this urethral incontinence must be determined before management is implemented. If the outlet is not obviously incompetent on exam, we commonly perform urodynamics to assess whether urethral incontinence is due to uninhibited detrusor contractions or outlet dysfunction. Uninhibited detrusor contractions can be addressed with oral medications, anticholinergics, beta-3 agonists, or intradetrusor botulinum toxin injection. On the other hand, outlet dysfunction is a problem that requires surgical correction. In women, outlet incompetence can be treated with urethral bulking, slings, or bladder neck closure. If the preserved urethral length is less than 2 centimeters, we generally proceed with bladder neck closure. Otherwise, we attempt to address the outlet with a sling, thus preserving urethral bladder access. For chronically catheterized patients, we almost exclusively use autologous slings that allow greater urethral compression than synthetic midurethral slings. For male patients with outlet incompetence, surgical options include implantation of artificial urethral sphincter, placement of an autologous puboprostatic sling, or bladder neck closure. We utilize the latter procedure when there is destruction of the bladder neck, which usually occurs in the setting of a large sacral decubitus ulcer extending deep into the pelvis and eroding the urethra and bladder neck. Conclusions. Chronic indwelling catheters remain a key option for patients whose comorbidities, neurologic deficits, or lifestyle challenges make alternative management methods infeasible. While they can provide reliable urinary drainage and relieve the burden on caregivers, their use demands ongoing diligence. Catheter-associated complications, ranging from routine obstructions and UTIs to more severe concerns like bladder outlet destruction, underscore the need for close monitoring, prompt intervention, and patient education. Did you know? Indwelling catheters are typically a last resort for managing chronic urinary retention or incontinence, reserved for patients who cannot use other methods, e.g. clean intermittent catheterization, external collection devices. Upsizing a urethral catheter to address leakage can worsen urethral or bladder neck injury rather than fixing the underlying problem. Suprapubic catheters avoid urethral complications but carry their own procedural risks, such as bowel or vascular injury, especially in high-risk patients. Hematuria in a chronic catheter user often warrants standard hematuria evaluation unless it clearly coincides with recent catheter exchange or trauma. Close monitoring and patient education can help prevent or promptly address catheter-related issues, such as infection, encrustation, and urethral erosion. For more information or to claim CME, please visit the AUA University at auanet.org/university.